What age do women typically start experiencing the menopausal symptom?
So typically the age is around their 40s, maybe late 30s, early 40s. A lot of women, when they're in their teens and they're getting their periods and they're starting to have the cycles, they have very little awareness of what the future will be for their menstrual health. So in perimenopause, you're getting this increasing insulin resistance. So we don't encourage any lean protein because then you will not be getting the fat.
Right.
So full fat everything. And that will help also your hormone production as well, because fat's the important building block to make your own hormones. Fasting becomes easier for women once they hit menopause. With fibroids, they are very prevalent. So many women who are having heavy bleeding, heavy uterine bleeding, often if we do a pelvic ultrasound, we can see multiple fibroids.
Do fibroids kind of reduce as a person hits menopause?
They can do because their hormone is not as high.
What's your thought on dairy products and dairy food?
In Australia, there is a restriction on this. It's actually illegal to be selling raw milk.
Hi, everybody, and welcome to another podcast. My name is Poshini Agastya. I am a consultant here at Arka Anugraha Hospital. Welcome to today's episode, where we have the privilege of speaking to Dr. Deepa Mahananda, a trailblazer in metabolic health and women's health in Australia. Dr. Deepa is the co-director of Sydney Low Carb Specialist, where she's specializing and revolutionizing how we approach the treatment of chronic disease management through low carbohydrate nutrition. She graduated from West Sydney University in 2012 and is a fellow of Royal Australian College of General Practitioners. She holds a diploma in child health and sexual health and family planning certification from the University of Sydney. What makes Dr. Deepa particularly unique is her dual expertise. She's a board-certified ketogenic nutrition specialist through the American Nutrition Association and is on the board of Australian Metabolic Health Society. She's also a co-joint lecturer at Western Sydney University, training the next generation of medical practitioners. Today, we are diving deep into a topic that affects every woman, the journey from premenopause to menopause, and how metabolic health plays a crucial role in the transition. Thank you, Dr. Deepa, for joining us here today for the podcast.
Thank you for inviting me and the opportunity to be here. I'm very excited to have a chat today.
I'm very excited to know more about the topic we've chosen, perimenopause and menopause. So why don't we jump right in and start with the fundamentals. What is the difference between perimenopause, menopause?
Yes, so perimenopause is a spectrum of time. It can go over quite a few years, sometimes for some women, even a decade. The time at which it normally starts is around the 40s, but it can start even earlier for some women in their 30s. And on average, most women will reach menopause around 51 to 52 years of age. And menopause is more defined. It's an arbitrary definition, but no periods for at least 12 months. However, most things in medicine don't often follow those concrete definitions. So we usually say that perimenopause is the journey and then menopause is your destination. But much can change in that time. And it's all about the changing hormones during this period of time.
What age do women typically start experiencing the menopausal symptom, and what do these symptoms look like?
So typically the age is around their 40s, maybe late 30s, early 40s. And the symptoms are usually linked to some change in their menstrual cycle. They may be seeing irregular cycles or longer periods or shorter periods, change in the consistency of the period. And that's just sort of the obvious types of signs that women might be observing. But if you look for more subtle signs, there'll be changes in their mood, their behavior, also in the way they might be feeling in themselves. They might have some gut discomfort, joint aches and pains. And there are many other cognitive changes like some short-term memory loss and that sort of thing as well.
What are some of the lesser known symptoms?
Yes, as I mentioned, the joint aches and pains is quite often lesser known, and also gut disruption. So some women will start to develop reflux or bloating and difficulties with constipation, or sometimes even diarrhea. So maybe a mixture of the two, where they never really had such symptoms before, but no obvious trigger. And then also there are some women who develop some problems with their mood, and all of a sudden a situation that they normally would have coped very well with starts to provoke anxiety out of nowhere. So I talk about it as anxiety or a mood change without a known trigger, and in a situation where they normally don't feel that way, or a sense of overwhelm where they can't seem to balance all the things they normally do at the same time. And so those sorts of subtle changes, a lot of women won't recognize because they can be leading quite busy lives. And it does take someone who's a sort of a third party, like usually a health professional, who may be able to recognize those symptoms in the person.
A lot of symptoms that you mentioned kind of overlap with burnout as well.
Yes.
How would you distinct the two?
And that period of time in a woman's life, their 40s and their 50s, is a time that I call the sandwich generation. So often they have older parents or people that may be caring for. They may also have children, partners, and a more extended family as well. And women have always traditionally held roles of being carers and often put themselves ahead of other people. So yes, it's a difficult time for them to manage because they can be quite busy and it's very stressful. And that can lead to the burnout component, which also overlaps many of the symptoms you see in perimenopause and menopause. So being in such a stressful state can make these symptoms worse and really bring them to the fore.
And is there an intersection of insulin resistance with perimenopause?
Yes, absolutely. So in perimenopause, you're actually losing 3 hormones. Traditionally, the focus has always been on the 2 primary ones, which is estrogen and progesterone for a female. But women, maybe a little known fact is that in a woman's lifetime, testosterone is actually produced at a higher level than the estrogen and the progesterone. And that hormone, testosterone, also declines through perimenopause, and then by menopause can be quite low comparative to previously. So as those 3 hormones are in decline, we will often see the hormonal changes that reflect as symptoms. And these are the things that can then lead into some difficulties for some women, because at times these hormones will be in different ratios to each other until they get down to a plateau or a baseline. And I think the original question you were asking there, sorry, I was coming to answer
Insulin resistance.
Oh, that's correct. So with the estrogen is the key component that relates to the insulin resistance. As estrogen declines, and often it declines as not in a linear fashion, but it goes in a zigzag fashion. So it's coming down, but a bit like this. And as that occurs, your insulin resistance starts to increase. So for a lot of women who come to see me in the clinic, they say, what worked for me to manage my body composition in my 20s and my 30s, quite easily working for me, no longer works anymore. And this is the time I need to explain that the change of one hormone, estrogen, is now influencing the way that the liver works. So the liver, it produces glucose. And when estrogen is in a higher peak, it actually reduces the glucose production, gluconeogenesis in the liver. And as that estrogen is coming down, then it's sort of like it's taking the brakes off that glucose production. So the glucose gets released into the bloodstream. This is independent also of the food we eat, but can also release the sugar. So that combination means there's a higher sugar or higher glucose load within the blood, and then our hormone insulin will need to rise. But then also in our cells, muscle cells, fat cells, those receptors start to not respond to the higher insulin. So hence the insulin resistance occurs. So there's quite a big change that goes on, and it explains for a lot of women why their body composition changes through this time. Especially they'll see this as weight gain, or what I like to say is the fat gain, because that's the swelling of the fat cells.
Right.
Yeah.
And typically women at this age, perimenopause, they're like, I've changed nothing, but I'm gaining weight is a typical sign.
Exactly. So there's no major change in their routine. But what they find is because the estrogen is in decline and they can't quite stop that, because we all inevitably go through a menopause, that's when it will be harder to continue to do the same routine. But there are many strategies you can do to overcome that.
Is there a connection between women, their menstrual health, and let's say early 20s, 30s, that would impact in perimenopause or menopause?
Definitely. So a lot of women, when they're in their teens and they're getting their periods and they're starting to have the cycles, they have very little awareness of what the future will be for their menstrual health. And, quite rightfully, they tend to live in the moment. So there's not much awareness of how conditions like, say, if you're diagnosed at an earlier age with some menstrual irregularities and it turns out to be polycystic ovarian syndrome, or there is endometriosis, which are two of the most common conditions in young women. When those are unrecognized or perhaps not well treated, and we don't look at the root cause of what was behind developing those conditions, that can then lead to vulnerability in the person's metabolic health later in their life. So, for instance, a woman diagnosed with PCOS will then have a higher chance of developing diabetes. And I think the statistics are that by the time a lady is in their 40s, and if they've had a PCOS history, there is a more than 50% chance of type 2 diabetes development and being diagnosed at that stage, which means that they're already getting this insulin resistance, which is a hallmark of type 2 diabetes, before they really enter their perimenopause. Okay. And that is what I describe as a double whammy. So you already have one insult, which is the insulin resistance of type 2 diabetes. And then you have your perimenopause happening, which is a secondary insult on top. So that makes it even more difficult to regulate and manage the symptoms that can get worse. So there is a strong association that with women who have some insulin resistance, their perimenopause will be more prolonged and more severe symptoms developing. And then also in endometriosis, which is another type of condition, that the hallmark there is inflammation. So there are a lot of inflammatory markers which we can track and measure that we see is quite high in this condition, because we now are tending to view endometriosis as more of an autoimmune condition. And any woman who had then been exposed to quite a high inflammatory state at a younger age is more likely to then also have difficulty regulating this as they get older. Yeah. So their inflammatory state is quite high, which can further worsen their experience of perimenopause. So to make that journey to your destination more smooth, it's important to address any condition that affects your menstrual cycle at an earlier age in your teens, 20s, and early 30s. And if there's any signs of fertility issues, to also consider that this could be a problem later down the track, not for the pregnancies or fall in pregnancy itself, but later in the perimenopause, menopause time. So I always highly encourage women to be proactive at the younger age, because that can prevent a lot of problems down the line.
And what does this proactive steps look like?
Yes, so those steps would look like, I always, much like I take heart rate, blood pressure, I always ask every woman in my clinic about their menstrual cycle, because I think it's a vital sign, just like all the other vital signs that we normally measure in the doctor's consultation. And if there is any problems whatsoever with that vital sign, I start to investigate. So the investigations there will be around different hormones, nutrient status, and understanding what their wider lifestyle is like. So are they, for instance, exercising? How is their sleep? What are they eating? And what are their relationships like and are they feeling emotionally well, stable, and settled? And if there's any problems with any of those, we need to look at each pillar of health and try to put in place those strategies. So that might look like making significant dietary changes, assessing how we can improve the sleep situation. And we go through each step by step. And often in a person or any individual we chat with, they will often have one area that is far more challenging than the others. And we tend to start there and then add on as we can get past each challenge, because it's easier to do these things as a bite-sized attempt rather than doing everything in one go.
I'll probably ask a question that I know is more related to a different subtopic, but I think it would connect well for 20s and 30s. What's the role of sleep that plays in perimenopause? Because I see a lot of youngsters not sleeping.
Sleep is a huge factor and sometimes dismissed, I think, because we often think of sleep as a commodity that we could just catch up on the weekend.
Right.
So what I do see quite often is people are burning the candle at both ends. So they tend to get up, particularly if they're working, they may be getting up early and going out to do their work and everything. But at nighttime, people might recreationally be on their devices, or they are procrastinating with getting off to sleep because there's just so much stimulation in their environment. So what that's doing is really impacting through the day their adenosine production, which is this hormone that is meant to be reaching its peak as we need to fall asleep at night. So for a lot of the patients I consult with, they're under blue light spectrum within their workplace, or they get very minimal outdoor time at all. In fact, some people, one of my questions often is, how quickly do you see outside light within 1 hour of waking up in the morning? And many people will actually look at me and say, I get ready, I go straight to my car, which is within a garage, and then I go straight to work. I'm inside a work environment all day, and then I'm back home. And then they look at me with shock saying, actually, I did not get outside light at all. And that's their day-to-day. And worse is the person who works from home, who does not leave their house. So our sleep is set up by what we do through the day. And our modern world is not well set up for full spectrum light, which is important to our adenosine and melatonin production. So, of course, these days we now have melatonin supplements and all sorts of therapies that are designed to band-aid the situation, but they never fix that root cause, which is our light environment being what it is. We need to work harder and smarter to understand how we get light, full spectrum light breaks through the day, what we do within that first hour of waking up. And then, of course, the role of technology in our lives, because we are in a digital world to an extent, and that impacts upon the sleep. And then if you bring this back to perimenopause, women will be experiencing symptoms like disturbance with their temperature regulation. So really, sometimes it's not so much hot flushing, but it's just that they're getting sweaty or just slightly hotter overnight than their partner, for instance. And they might wake up having to throw off the sheets, but just the wake up, that disruption to their sleep cycle, means that they'll be waking up the next morning with a higher cortisol level, right? So every night there is a bit of this stressful event going on, and depending on the number of sleep disruptions, the worse this will become the next morning for cortisol. And cortisol goes on, a high cortisol goes on to create an insulin resistant state, which we've talked about is one of the double whammy effects. So yeah, I think in our modern world, with what's happening in our light exposures, plus then symptoms that might disturb the sleep, the other lesser known symptom is waking to go to the toilet. Often becomes worse in perimenopause and menopause because of vaginal dryness. So you're getting a loss of that estrogenization of the genitourinary tract. And when that happens, a lot of women will say to me, yeah, actually, I do tend to wake up now to go to the toilet where I never used to wake up. And that's another sleep disruption. Right. So we can treat that and we can work on that to minimize the number of wake-ups. So the better the sleep quality, the lesser the problems through the day, and over those years that the perimenopause journey occurs will be smoother as well.
I don't know if it's appropriate in the podcast, but it's sexier to prioritize your sleep even in your 20s as opposed to...
Yes, and definitely those habits that are created at a younger age are easier to maintain as you go through your life. And especially now with that being connected all the time,
Right.
it's very important for us to be able to have a point or a boundary at which we do switch off. And I really work with my patients to encourage them to set aside time that is their own time offline in the real world, also outdoors as much as possible.
Sure.
So to really aid the sleep.
Yeah. I think the easy way to do that is you're drinking your coffee in the morning, take it outside.
Absolutely. Or you need to take a phone call, step outside.
Yes.
I call them little breaks. So you might, and that also involves you getting up and movement. So they're all things that we can just integrate without too much difficulty into our lifestyle.
Sure. So one of the things that you mentioned is there's a connection between dropping of the three main hormones, the sex hormones, and the role with the insulin resistance, which again is a hormone. You spoke about adrenal. What about thyroid issues?
Yes, so thyroid issues are common to see around at the same time or concurrently with perimenopause, and even as you approach perimenopause. So with the thyroid hormone production, that can tend to be leading to lower amounts as your estrogen declines as well. So there is an influence there. And many women can get through that time without too much disruption. But if there is a pre-existing thyroid condition, for instance, a Hashimoto's disorder, that can mean that this drop-off will get a little bit more pronounced. So there does need to be some adjustment to the way we manage the thyroid disorder at the same time during perimenopause. The other thing to note is that the nutrients that someone is consuming during any part of the perimenopause transition is very important, because our thyroid hormone, which is mainly our T4, which is inactive, and it gets converted to the T3, which is your active hormone. The T3 hormone is responsible for all our body's processes.
Yeah.
So we need it to actually go inside our cell to have an action. Getting inside the cell also depends on what nutrients are circulating, specifically zinc. Zinc is a very big one. And the other big nutrients that the thyroid require are things like B12, vitamin D, iron, which classically in the women I see can be quite low. And it's usually because in an effort to, say, lose weight, someone might be restricting themselves in volume of food intake. So they're just not getting anywhere near the amount they need. And in some women in perimenopause, they may have very heavy bleeding, and they're also losing more iron than they can recruit in their diet. So the worsening iron deficiency leads to also a vicious cycle on our thyroid gland as well. So sometimes some of the issues that are happening through perimenopause can go on to precipitate a thyroid issue, or if you had a pre-existing thyroid issue, that can get worse. So there is a very strong interconnection between these two. What I do to try and ensure that we're covering both and making sure we address both at the same time is to test regularly the thyroid gland and its hormones. So doing a full panel is very important. And also understanding whether someone's level of insulin resistance. So we can do fasting insulins. We can look at insulin resistance and glucose ratios. And then put together a bit of a plan to ensure also that all nutrients are checked as well, so that we can make sure the thyroid has all the building blocks. The one I didn't mention, which is probably very critical, is iodine, because iodine is thyroid hormone. It's just iodine holding hands. So in Australia, where I'm practicing in Sydney, we have a very deficient soil, iodine content in our soil.
Right.
So there is a high incidence of thyroid disorders, particularly amongst women. And it's for that reason many prenatal vitamins contain iodine. But often, apart from the time of pregnancy, women are not focused on iodine. They have no awareness that it's important, as well as the B vitamins. Yeah. So we encourage an awareness in the food intake that we need to be either taking in some salt that is iodized, which is one option, or to take in food that has some naturally occurring iodine content. So it's quite an important area, which I think is quite overlooked generally speaking. And if you can support your thyroid well through the perimenopause transition, again, it won't exacerbate your symptoms of perimenopause, and it can keep things in check. And sometimes women have their perimenopause symptoms misdiagnosed as a thyroid condition, right, and vice versa. Yeah. Because they do overlap one another, yes, quite extensively. You can feel the slowing down on either side. And so that's when we do need to just tease apart which is which, and also recognize that they are interchange between the two of them as well.
You were talking about specific. So what are the specific nutrients women should be prioritizing?
Yes.
Yeah, in perimenopause. So are they different from perimenopause and menopausal nutrients?
Yeah. So in perimenopause, you're getting this increasing insulin resistance. So the areas that really need focus is that we try to encourage people to avoid ultra-processed foods as a basic fundamental, keep sugar intake low, and then addition to that is to increase their protein intake to their level of activity. So we often encourage people to engage in resistance training to build their muscle mass. But while they do that, they need to bring up their protein intake, which usually should be somewhere between 1.5 grams per kilogram of body weight or lean muscle mass, upwards of 2.2 or even 2.5, depending on how much resistance training is being undertaken. So there is a spectrum which we can individualize. And then on top of that is to understand, again, yes, what's the consistency, heaviness of periods, and ensure that they are getting adequate iron particularly. So sometimes that the focus on protein can help lift that iron, because a lot of the protein intake that is animal protein will contain it. But if someone does not eat animal products, then we can focus on protein within a vegetarian context. So we do try and really work hard to bring those aspects up. The other one is vitamin D, and understanding that fat is incredibly important to our food intake. So fat-soluble vitamins like vitamin A, D, E, and K will be coming in our natural fat sources. Yeah. So we don't encourage any lean protein, because then you will not be getting the fat.
Right.
So full fat everything, and that will help also your hormone production as well, because fat's the important building block to make your own hormones. So these are some of the specific dietary changes that need to be made around perimenopause, and then strengthened as you get towards menopause. There is also a component of fasting that people often ask about. I don't tend to encourage fasting during perimenopause unless there's a specific need for it, from a gut health perspective or to treat morbid obesity. That is a specific time at which you can do some supervised intermittent fasting. But generally speaking, fasting becomes easier for women once they hit menopause.
Yeah.
And then it's much easier when there's no influence from hormonal fluctuations. The other thing that can help women is fasting with their cycle.
Yes.
So in the first 10 days from the day 1 of bleeding through to the 10th day, that is a time where fasting can be used without much harm or without much stress to the body. And after that, until the next period, we would discourage any fasting, any forced fasting. So that's just another way for us to work with the known insulin resistance that occurs in the second half of our menstrual cycle. So we don't want to make that add on another stress during that time. Right? So that's the reason we talk about fasting having a specific guideline to it.
So the primary nutrients are fats, proteins, all the B vitamins.
Yes.
what's the role all of this plays with insulin resistance and your liver health? What's the connection with fibroids?
Yes. So with fibroids, they are very prevalent. So many women who are having heavy bleeding, heavy uterine bleeding, often if we do a pelvic ultrasound, we can see multiple fibroids. Now, a fibroid is simply a growth from the lining of the uterus, and it has a very strong association with insulin resistance. So many of those women with the fibroids will show some level of insulin resistance. And that's because insulin is also a growth factor.
Yeah.
And it has that influence on the lining, which is heavily vascularized. So there's a lot of blood flow to that area, hence a lot of nutrients heading there. And that perfect storm of the insulin resistance can cause some growth. So my first, reaction to managing these patients is first ensure they're quite stable, because if there's an unstable amount of bleeding, that means it's focused first. I really try to, I just want to try to prevent removal or unnecessary surgical procedures, which often is the case for a lot of women, is first up they're suggested straight away to have it removed.
Yeah.
Removing it does not sort out the root cause. So even if they required removal for the severity, it's still important for them to understand that they can stop the regrowth of this issue if they can address what is being supplied to the area.
So it's possible to have the fibroid shrink, but it's not always
the case. And of course, this is why we have that fusion between all the traditional therapies that we have available. But as well, we can always use these adjunctive lifestyle measures to reduce the frequency, recurrence, and the severity of these conditions.
Do fibroids kind of reduce as a person hits menopause?
They can do, because the hormone is not as high. Right. So they're often influenced also by estrogen and progesterone to a lesser extent, testosterone to a lesser extent, but it's usually estrogen that has the biggest influence on growth.
Right.
So yes, they can then be, maybe stop in their growth and or reduce.
Right.
But yes, in some women that does not occur, so they may still require a surgical removal if it's a problem.
A lot of people consume soy products and phytoestrogen during menopause, during perimenopause. What's your clinical advice on this?
Yes, so soy is known as a goitrogen, or it's become more, there's more research to suggest that it can actually worsen our thyroid health. So I guess there is still a role for the use of soy, particularly for the person who can't have other sources of protein. So my advice is generally, if you can eat other sources of protein, it's best to minimize and or avoid soy where possible. If you need to consume the soy as a primary source of protein, then ensure that it is a non-GMO sourced soy, and ideally organic soy production, mainly because the glyphosate that's used in the farming processes for soy is known as a forever chemical within our bodies, and that can also act as a hormone disruptor for women. So it's sort of the combination of it being known as a goitrogen, plus also the chemicals involved in its production that can be quite disruptive to women's gynecological health and hormone health. So yes, that's sort of the advice, but definitely has to be balanced with that person's individual capacity to accept other proteins.
All right. Since you were talking also about vegetarian and people who need to depend on soy, what's your thought on dairy products and dairy protein?
Yes. So look, generally dairy protein it's very highly consumed worldwide. Cow's milk being the primary dairy protein, but to a lesser extent sheep milk and goat milk is also consumed in many parts of the world. And in terms of cheese production, all of those three types are used extensively. I think milk has changed over time. So again, this is influenced by our agricultural processes and how we care for the animals, what the animals consume. So the quality of their feed, the quality of their health influences the milk that they supply. So wherever possible for a person who does want to consume dairy, best to get, again, a organically sourced or at least a cow who has been on pasture rather than grain. So that just helps the nutrient composition in the milk be higher quality. And in some parts of the world, we can still access raw milk. So it's unpasteurized milk. And in Australia, there is a restriction on this. It's actually illegal to be selling raw milk, unfortunately. And that is because of the concerns around bacteria in the milk, which can lead to a severe illness. So if you know a producer, or if you can trust that it's been produced in a good environment, raw milk is the preference. But if you're not able to achieve that, then at least an organic option. And then worst case scenario is something that's unhomogenized, because that means at least you're getting the cream component as well within your milk, which has all the fat soluble vitamins. Now, milk can be a problem for some people, and that's mainly for autoimmune conditions, because the proteins in milk can be perceived by the body as foreign and cause an immune reaction. And that can stimulate the gut's innate immune system. So for people who are struggling and they've changed a lot of their lifestyle, but the autoimmune condition is still very strong and symptomatic, we usually then advise an autoimmune protocol which involves dairy removal, because it could well be that the dairy is a contributing or triggering factor. And then the last issue I see with milk is to do with casein, which is the casein protein within milk. It binds to our opioid receptors in the brain, which can mean that some people find it's actually quite difficult to give up dairy because it is a bit addictive. Yeah, it's a bit like morphine, which also binds to our opioid receptors. So taken for a long time, over a period of time, we actually have a bit of a dependence then on dairy. So it's no wonder we give even milk to a child to almost fall asleep in the night. It's sort of a bit of a tradition in many cultures. But actually that's because it's binding to this feel-good, relaxing receptor. So when we work with our patients who have identified food addiction or harmful use of food, we often do advise a removal of dairy, because that helps them to overcome the addictive components that they just actually, it's not so not so well perceived by the patient, but you can see that they are having a high dependence on the dairy as a way to keep calm. So we usually reduce that and bridge to other options rather than remain on a dairy product. So that's the issues, I think, with milk or dairy products, because they aren't, it's once you scratch the surface, there's a few other things to identify. But if a person is consuming it and they can honestly say, I feel pretty good in myself and quite optimal, it is a good source of nutrients and protein, so and fats. So we do often allow that to then stay in the food approach. It's only really if they're showing other problems.
Right. Do you help a person decide between soy and dairy?
Yes.
I think for a vegetarian, these are the two top sources.
Yes. Preference is always dairy products as opposed to soy. And then, yes, just the quality needs to be ensured, because there is a way to do it with a quality option and a way to not. And then if you're having a lower quality option, you just need to understand that it can have some side effects. And keeping the volumes lower, or a little bit more variety with the types rather than just dairy or just soy all the time, because that can then, particularly with soy, lead to it becoming a goitrogen.
Right.
Or excessive estrogen, because it's known as a phytoestrogen as well. It acts like an estrogen in the body. So that can be disruptive to our perimenopause.
I think this jumps right into the next question very well. What's the role of adrenal health? Because we've given contrasting views on both soy and dairy now.
Yes. So on adrenal health, in perimenopause at least, we've spoken about how it's a stressful time just dealing with symptoms, but also the sandwich generation and work stress. So there's a lot of areas that can be pressuring upon a person. So our adrenal health is essentially intertwined with that level of burden or stress. The more stress that someone is under, the higher cortisol production there will be. And that actually can really block the conversion of hormones within the body. So particularly from the adrenal gland. So in helping a woman navigate that period of time, it's really important to educate about the connection between the two. Estrogen can drop faster if we're under a lot of stress, and that's simply because we block that conversion of a precursor of our hormones called DHEAS. And when that's blocked, we cannot produce the estrogen our body requires for maintenance of our menstrual cycle. Even though our menstrual cycles may be becoming irregular, we still require some conversion to be going on. So adding on that stress and what we tend to call adrenal fatigue occurs, and that can be another big spanner in the works through perimenopause, forcing upon a woman a lot more severe symptoms and a more disjointed perimenopause transition. So best to try to do all the work we can to minimize that cortisol response in our adrenal glands.
And how does excessive intermittent fasting and excessive over-exercising, overtraining, all of this play a role with the cortisol?
Absolutely, because it again influences that adrenal gland mechanics, and it shuts it down. Right. And when that shuts down, we tend not to have a cycle and we don't ovulate. And then we end up with this problem of estrogen and progesterone mismatch. So intermittent fasting, that's one of the big reasons we suggest timing is very important, and also trying to minimize doing it for a very long time so that it doesn't become a stress. It can be a very powerful, effective tool that done too much, it becomes a adrenal stress. And then also with over-exercising, that can become, and that's a trap for a lot of people because they would feel that just exercising in their 20s and 30s does what it needs to do for them to maintain their body composition and not change what they eat. But then the effort to over-exercise continues to grow and grow if they don't get the advice about how it's actually not moving more that's going to improve their health. It's going to be about changing what's going on at the hormonal level and what they're consuming. So that's the biggest intersection to understand, is that these things that are good can actually become too good and then overstress for our adrenal glands.
A lot of women are using birth control pills well into their 40s and later as well. And they don't realize they're in menopause. So what are they supposed to do? What are some key takeaways on this part?
Yeah, the birth control pills, oral contraceptive pills, they basically reduce our own natural production of estrogen and progesterone, and to an extent testosterone too, by influence. And it's because they are giving us relatively high doses of usually a synthetic estrogen and progestin. So these two things can mask menstrual irregularities, because when a woman takes the pill, they usually will see, if they are taking the sugar pills or the placebo pills, they will usually see just a regular period. But really that period is just a withdrawal bleed from taking the hormones away for 7 days. So it's not truly a cycle that is controlled by our body. It's purely artificially controlled by the way you're taking the pills. So you'll take 21 days typically of the hormones and then 7 days no hormones, and that's where we see a bleed. So that done over a number of years, and there's two sort of issues with that. The first issue is the research is showing that if you have taken a pill for more than 6 months continuously, that's the point at which you will often notice there are nutrient deficiencies. And women, again, are not provided informed consent about this particular issue. We often see this in the setting of fertility treatment, where a woman has been on a contraceptive pill, then wants to fall pregnant and immediately comes off it hoping that they'll fall pregnant straight away. But what has happened in the time they've been on the pill is it's reducing the absorption of key nutrients, particularly vitamin B9, which is folate. And by the time they're then ready to fall pregnant, they have very low folate. And we need high folate for spinal development, the neural tube development. So that's one issue in and of itself, is that it reduces our absorptions of key nutrients the longer you are on the pill, more than 6 months. Then beyond that, as it affects perimenopause, women who are, say, in their late 30s, early 40s, still taking the pill will not notice that they are entering perimenopause because they are masking artificially their cycle. Yeah. They're not having their own cycle. They've already reduced their own production of their own hormones. They're almost in a menopause state without knowing.
Oh, wow.
And what I normally would suggest then is either if there is no dramatic need to take the contraceptive pill, we go to lower dose hormones as an alternative. So there are more local hormones. So if it's purely about contraception, then we would usually recommend a intrauterine device, maybe a Mirena. Levonorgestrel is the coated device that can be inserted to the uterus, and that just can be used as a contraceptive. So local is best. Otherwise, we could transition to some bioidentical hormones that are more designed to address perimenopause symptoms, and they're at much lower doses than what is seen in the oral contraceptive pill. Right. So then it's easier for a woman to be aware of any symptoms rather than masking it with a very high dose of hormone all the time. So that's one strategy. And then, of course, the strategy of withdraw the hormones entirely and simply observe what's happening for 6 months or even a shorter time period, just to see if there's still a cycle, if there's any symptoms, and then we can go in and address simply those symptoms. So that's one way to kind of come away. I think all women should think about beyond the time of using it as contraception or for any other, usually it's given for management of things like PCOS or endometriosis. I think it's an important way to understand what's truly happening with the body is to withdraw it and see what's going on. Yeah, because it is a Band-Aid. It's always been a Band-Aid when it's used for these conditions. But as for contraception, it is a liberating thing for women, yes, but there are versions of doing it that can be less problematic for women as well, yes.
Also, a lot of people hesitate to come off the birth control,
yes.
And not just because of the convenience of what it brings about, also they see mental health, mood, stability.
Yes.
Even to see for 6 months what's going to happen if I'm off. They don't like the way they feel. They don't like the anxiety, the panic. And they are typically the perimenopausal symptoms that's showing up.
Yes, because that is that intersection of, like we use a screening tool. It's called a Greene Climacteric scale. So this screening tool has about 30 or a bit beyond 30 symptoms that we ask women to grade. Are they experiencing it frequently or infrequently? And if they're scoring more than 12 on this scale, then we know that their perimenopause symptoms are likely symptomatic and having an impact on their quality of life and therefore require some management strategies. If the score is under 12, that doesn't mean we dismiss, but we still need to be aware of what those symptoms are. And they sometimes transit certain body systems. So I talk about the cognitive symptoms of menopause, which is what you were referencing there, which is that fear that I'm going to get a lot of premenstrual distress and in the lead up to my next period, or I'm feeling very anxious and irritable. My partner irritates me no matter what they do. If they breathe, it makes them angry. So there's a lot of, sensitivity to from a cognitive standpoint. And that is actually to do, there are some mechanics beyond that. So when estrogen is in decline, we can get neuroinflammation because estrogen, particularly estradiol, which is E2, is actually brain protective. And as that lowers, we tend to get this problem with the brain function, and it also affects short-term memory and those sorts of areas of the brain. But we can get around that by addressing a better fuel source for our brain cells. So rather than being on a sugar predominant or carb predominant diet, if we can provide another fuel source through higher fat intake and producing a really good fuel called ketones, which can transit into the brain, that can actually calm neurotransmitter connection as better fuel source for brain cells. And the preference always has been ancestrally for our brains to function on ketones wherever they're available. Right. So that's always the fuel source we prefer. If sugar is there, then preferentially we have to get rid of that and then move back to ketones. But if ketones are the predominant fuel source, that's always been ancestrally what our brain prefers. So these are things, I always acknowledge that women will have that anxiety, and I say this is simply a trial, come off. We can always go back on, so that's the default if it is very severe. But in preparation to come off, we do the groundwork.
Right.
So all the fundamentals we start to put into place. We can even do that before we cease the medication, right, so that they're in a better off state when they come off the hormone. And then we can target what is remaining. You know, they might say, oh, actually now my premenstrual distress is not as severe, but it's still there. Okay, so this is then what we need to do. Maybe we'll introduce some breath work or some sympathetic nervous system treatment. So that's a time we can then start to do more work around that. But I do think it's not insurmountable. But I know a lot of women are worried, especially when they're coming off. Yeah.
We will link the scale that you were mentioning in the podcast.
Yes. The Greene Climacteric scale. Yes. Right. And anyone can go through those questions and self-assess. And that is actually a very helpful tool to keep track of what's happening, which systems of the body are affected, and also what could be targeted with treatment. Because sometimes it's certain aspects. It could just be cognitive, right? Could be the temperature fluctuations, it could be genital urinary symptoms, or it could be a mix of everything. So this really helps yourself and the health professional navigate how to put management in place.
So do you recommend a difference in carbohydrate intake for perimenopause and menopause? Is that?
Yeah, definitely. I think it always needs to be tailored to what is seen in the blood tests, because if a woman's insulin level is above 8, generally speaking, we would say that is in a territory where they're likely to be storing energy as fat. Right. We really need to get that number to drop under 8, and this is fasting. So that means we must try to reduce the carbohydrate to the point where they can tip underneath that. And if they are already very low carbohydrate, so say in what we would suggest as the ketogenic spectrum, that's under 30 grams or maybe under 20 to 30 grams of carbohydrate per day, and it hasn't yet tipped under 8, which I do see often, yes, that's where it's also the other factors like stress and sleep disruption. So then we need to shift our awareness to don't further work on your diet. Now we need to keep this, but add on all the other measures, which is usually the problem actually in perimenopause and menopause. So the food framework can quite easily be achieved and tailored, and you may need lower carbohydrate as time goes on to address it, but it's often in conjunction with the other therapies that we need to look at.
So beyond diet, what lifestyle factors most impact menopausal symptoms and perimenopausal symptoms?
I think exercise is incredibly important, but not just any exercise. So a lot of people will come to me and tell me, I'm very active. I walk every day. I might walk the dog. I do a lot of yoga, or I do lots of Pilates. I'm going to classes every day at the gym. And some people are doing CrossFit or some sort of, high intensity training, F45, all of those sorts of activities. And then I sort of sit down and I say, look, how much of this is cardio type activity, which is purely getting your heart rate up with lighter weights, which is not necessarily what you need in perimenopause and menopause. Because at this transitional time, the most important thing, two important things we need is increasing or stable, like least stabilizing, or ideally increasing our lean muscle mass. Yeah. And the second thing we need to do is ensure our bone density doesn't drop. Right. And it used to be thought we could not increase our bone density beyond menopause, but that's been disproven now. We can actually increase bone density over our lifetime as long as we're still putting mechanical stress, but with a stress that is not overstressing the bones, as well as eating the right nutrients, which is ideally the protein in our diet. So that is a huge key there. And so I encourage resistance training. And this is where we're doing push, pull, lifting movements. And more recently, I've come across the weighted vests. Yeah. So I do encourage my patients who can't necessarily go because they're injured or they can't lift a heavy weight. There's a joint aches or pains. There's unusual symptoms of perimenopause. Perhaps a weighted vest, which you can grade. So many women can start at 3 kilograms as the lightest and end up at 8 kilograms as a higher one and go for walks. So it's more value for the time spent of walking. So say you're spending 20 minutes walking every day, you're actually doing it against resistance because simply walking is only loading your legs, whereas this then loads your whole torso and legs. So there is a way to increase the effectiveness of doing the exercise. So those are some strategies. And then as we spoke about earlier with sleep and social connection. So trying to engage in ways to keep the mind active and the dopamine release that happens when you're engaged with people in real life and you have conversations, and ideally trying to do that in person as much as possible, because the whole movement towards work from home and the disconnect of being online, ironically, is actually quite detrimental to a woman's health. And they need that support and that emotional connection. So it's important for them to strengthen the relationships they have and work on building relationships as well as interests in their life as well. So that is the other strategies I think are important.
How can women navigate this transition in a culture that is often stigmatizing aging?
Yes. So we often think, oh no, like I'm not, I'm getting older, this is a problem. We tend to label aging as some kind of disease, and that's been a real medical framework. But in many cultures, traditionally, it is celebrated because we celebrate the wisdom a person has with their cumulative experience in life. So I think it's refreshing. I see in our professional networks that people now speak about, rather than your lifespan, which everyone is, living to an older age, usually on average now 87 years of age. But it's not so much living longer, but it's living longer with a good quality of life. And that's called the health span. Yeah. And yes, though, there's always been this stereotype that once you hit menopause, your body is never the same again, and it's all downhill from there, tends to be what has always been the rhetoric around menopause. It should actually be seen as a time of growth in oneself, and it takes a lot of strength for a woman to acknowledge that there's certain parts of their life they need focus on, especially in a time where they're in that sandwich and everything is about everyone else rather than themselves. So it's a reminder to come back to taking care of oneself and also where they want their life to be, because at that point, usually people are reaching, say, the middle of their career, or they're looking towards retirement and how they will be fulfilled and satisfied in their lives. And if we want to lead longer lives, which we will tend to do these days because of our great medical care, we want to lead fulfilled lives where we can actually do everything we want to do. And that part of it is where it takes our motivation to our health. and to prioritize our health and make time for the health, not for other things that will destroy health. So, yeah, this is where I see that the conversation is changing, and the medical framework is very slowly, but definitely changing in that direction.
What's your advice for women who are struggling to get their partners, families, even healthcare providers to understand what they're going through?
Yes, it's important to recognize it's not just in your head, which is what is often said to people. Husbands or partners might, say, blame the women for a problem with the relationship because they're changing, and somehow it's only the woman who needs to go work on things. But I think what works really well is men, particularly having a better understanding of what women go through during this transitional phase, because if you compare it to a male's lifetime, they do decline in testosterone, but nowhere near as dramatically as perimenopause and menopause. And they also decline in estrogen and progesterone too. So we all, both males and females, make these hormones, but it's always a gradual decline in a male, but in a female, it's a very abrupt off a cliff type decline. So that having that basic fundamental understanding means that they can at least have a good deal of respect for what a woman is going through and provide support and space and encouragement for the relationship and their partner seeking some assistance if required. And then also from the health professionals involved in care, many of them that I've worked with unfortunately don't have a good understanding and can be very dismissive because they're not aware. I don't think they mean to do harm,
Right.
but we don't taught a lot in medical training, at least where I trained. It was a very small niche part of my medical training.
Yeah.
But I do think it needs to be a wider discussion so we can understand that these symptoms a woman might turn up with are not just a specific system issue. Oh, that's just your thyroid, or that's just your mental health, and therefore you might go and see an endocrinologist or you might see a psychiatrist. But understanding and looking at the big picture and saying, actually, this is all connected.
Yeah.
And this is natural. There's the transitions you're going through, but we just need to do a different framework now.
Right.
And that could save 2 years worth of misdiagnosis, which is classically what I have heard from my patients. 2 years of being mislabeled, diagnosed with something, small Band-Aids, until it got really bad. So I think it will take more education of our society to make this less stigmatized and more open a discussion, and encourage women to speak about their symptoms as well, not just put up with it.
Right. To kind of come towards the ending, because I want to sum it all up, but there's one key factor that we haven't spoken about.
Yes.
Environmental toxins.
Yes.
How does that play a role in women's health through perimenopause, menopause?
Yes. Big role, because we have a movement at the moment towards things that are cheaper to make, that last longer. So just that movement towards that means that there is more BPA in our plastics. So it's called bisphenol A and phthalates. And this also exists in our receipt paper that we handle. So anyone who's touching receipt paper will be having these, what we call them endocrine-disrupting chemicals absorbed into our skin and therefore into the bloodstream. So these are chemicals in our world that we can try to minimize and reduce our use of these single-use plastics and even other plastic containers that touch hot food. So a big culprit is the coffee cups, takeaway coffee cups. I usually advise straight away to change to a reusable ceramic or steel container or glass. And also other things like makeup and beauty products, which a lot of women will find as they go through perimenopause, menopause transition, their skin, hair, nails change. That's quite normal. And it's because of the loss of estrogen in the dermal layers of our skin. And in an effort to change or to keep up the appearances that they had before, they often use a lot more products, which can be quite chemically laden, again, absorb and disrupt their own chemicals and make the very issue they're struggling with, perimenopause, worse. So these are why we often say, yes, it's important to do an inventory of your products that you breathe in, you eat, that go on your skin, that are in your environment, and make sure that it's as low toxin as possible. We usually cannot reach zero, and we don't want anyone to reach zero because that can be quite stressful in and of itself. Yeah. But whatever is within a person's capacity to do will make a difference.
Sure. So in conclusion, what's your vision for the future of menopausal care? What do you hope changes in how we support women through this transition?
So my hope for the future of care is that all women can access information, credible information, evidence-informed and evidence-based information that will help them make lifestyle changes that set them up really well for the time of perimenopause and menopause. So this really means younger women being aware about this, and for the women who are already in the transitional phases, that they can also access this information and not be fearful to have things like assistance with their hormones if required, because we know that it is a lot more safer now. We have a lot more options, and even within our lifestyle therapies, there's a lot of options and changes that people can opt for. And then more than that, I hope that other health professionals get better at identifying perimenopause earlier, because if we could get to it within that few months or a few weeks of it starting, then we can have a greater impact before it starts to disrupt the quality of life. So any woman, my hope would be any woman can get through perimenopause and menopause in a smooth transition and then have a great lifespan and health span at the same time.
Thank you so much, Dr. Deepa. It's really been wonderful. I think we diverted a lot from what we did, but we kept to a lot of what we planned as well. It's been very informational, and I hope our audience gets to enjoy and have a lot of questions. Thank you so much.
Thank you. Thanks for having me today.